Assalamu alaikum. My name is Dr. Shesha, and I'm going to present today's core urology lecture. It was being moderated by Dr. Bilal Masood, but unfortunately, he has some urgent piece of work. So, Dr. Bilal is here to help me. The topics of today's discussion would be the epidemiology, risk factors, screening, clinical presentation, diagnosis, and staging of prostate cancer. And epidemiology would include the incidence, mortality, racial differences, age at diagnosis, and stage at diagnosis. So, prostate cancer is the second most common cancer and the fifth leading cause of cancer deaths worldwide. Among men alive today, it is estimated that approximately 1 in 8 will be diagnosed with prostate cancer, and 1 in 40 will die from the disease. Prostate cancer is the third leading cause of cancer deaths in the US, accounting for 8% of all such events. Prostate cancer mortality rates in the US rose slowly between 1973 and 1990. Subsequent to 1991, which was the peak mortality year, steady declines in prostate cancer mortality were reported in both Caucasians and African Americans at an average rate of 4.1% per year. The African Americans and Jamaicans of African descent have the highest incidence of prostate cancer in the world. Although African Americans have experienced a greater decline in mortality than the Caucasians since the early 1990s, their death rates are still 2.3 times higher. Prostate cancer is rarely diagnosed in men younger than 50 years of age, accounting for only 2% of all such cases. Before the PSA era, the median age at diagnosis was 70 years, falling to 67 over the past decade, with 63% diagnosed after 65 years of age. Since the introduction of PSA testing, 81% of newly diagnosed men have localized disease, whereas the incidence of metastatic disease has decreased by 75%. Of course, because when PSA testing is done, so we can quite early know, we can know beforehand that there's something going on. The use of PSA has also resulted in a substantial downward pathologic stage migration, as evidenced by an increase in the proportion of patients with organ-confined disease, and a decrease in the proportion with seminal vesicle involvement. Now, coming to the risk factors, it is influenced by the familial and genetic germline influences, inflammation and infections, the role of androgens and estrogens, insulin-like growth factor excess, leptin, vitamin D and calcium, and other influences like smoking, diet, obesity, and alcohol. Prostate cancer has a strong familial component. The inherited risk for prostate cancer has been estimated to be as high as 60%. The culprit genes are BRCA1, BRCA2, and HOXB13. Several prostate cancer susceptibility loci have been identified on these much chromosomes. Inflammation leading to cellular hyperproliferation to replace the damaged tissue contributes to the development of infection-associated cancers of colon, esophagus, stomach, bladder, and liver. And similar process may underlie the development of prostate cancer, but no specific infectious agent has been identified yet. Inhibition of conversion of testosterone to the more potent dihydrotestosterone by alpha reductase inhibitors reduces the incidence of prostate cancer by about 25 to 30%. Traditionally, estrogens have been considered protective against prostate cancer and have been used as a treatment for advanced disease. This treatment effect is primarily through a negative feedback on the hypothalamo-pituitary gonadal axis, and also through a direct inhibitory effect of estrogens on prostate epithelial cell growth. The insulin-like growth factors promote proliferation and inhibit apoptosis in normal prostate and tumor cells in vitro. Leptin is a peptide hormone.
ये एंड्रोजन एस्ट्रोजन वाला जो है ये पाथवे ये कहाँ पे बेसिकली कहाँ पे इसकी वो होती है सिंथेसिस और वो, बिकॉज दिस पाथवे इज वेरी इंपॉर्टेंट इन द मैनेजमेंट ऑफ द प्रोस्टेट कैंसर, स्पेशली एडवांस प्रोस्टेट कैंसर। किसी को आइडिया है? कोई बताएगा? निशान? हाँ, तो टॉपिक है बीपीएच। टेस्टोस्टेरोन कन्वर्ट होता है ना डायहाइड्रोटेस्टोस्टेरोन में। टेस्टिस में होता है, एड्रीनल में होता है, कहाँ पे होता है? हाँ, सारे ऑप्शन दे तो दी। सबको बताया हुआ है। ज्यादातर प्रोस्टेट ओपीडी करने वालों को बताया हुआ है, मतलब नोबडी हियर्स। ये लोग बोलते हैं कि पीछे से जो बता के जाते हैं सब झूठ बता के जाते हैं, यही ना? सीनियर्स झूठ बता के जाते हैं, क्योंकि आपकी मेजोरिटी जो मैनेजमेंट है प्रोस्टेट कैंसर की वो इसी पे डिपेंड कर रही होती है। इवन के जो आप बीएसओ और वो करते हैं मेडिकल, जो हार्मोनल थेरेपी है वो सारी इसी पे बेस कर। चले आगे। बॉडी में सिर्फ एक ही सेल है जिसमें टेस्टोस्टेरोन कन्वर्ट होता है डायहाइड्रोटेस्टोस्टेरोन में, और बॉडी में कहीं पे कुछ नहीं होता, एंड दैट इज स्ट्रोमा ऑफ प्रोस्टेट, मसल सेल ऑफ प्रोस्टेट। प्रोस्टेट के स्ट्रोमा के लिए एपिथेलियल सेल में भी टेस्टोस्टेरोन डायहाइड्रोटेस्टोस्टेरोन में कन्वर्ट नहीं होता, सिर्फ स्ट्रोमा ऑफ प्रोस्टेट, और ये मैं कई मरतबा बता चुका हूँ।
So, leptin is a peptide hormone produced by adipocytes, which contributes to the control of body weight by appetite suppression and modulating energy utilization. Obese men become leptin resistant and exhibit elevated plasma leptin levels. There is evidence that leptin plays a role in the development of advanced disease. So now the role of vitamin D and calcium. Prostate cancer cells express vitamin D receptors, and many studies have demonstrated significant biologic effects of vitamin D, including inducing cell cycle arrest and inhibiting invasion, cell migration, metastasis, angiogenesis, and inflammation. So vitamin D can be considered as an inhibitor in the formation of prostate cancer. Dietary intake of dairy products, which are rich in calcium, depress the serum levels of vitamin D and is associated with a higher risk of prostate cancer. So these two have opposing effects. Other influences like cigarette smoking may be a risk factor for prostate cancer because it is a source of cadmium exposure, increases circulating androgen levels, and causes significant cellular oxidative stress. Obesity has been shown to be associated with higher rates of biochemical failure after surgery or external beam radiotherapy, and a 15 to 20% increase per 5 kilogram per meter square increase in BMI in prostate cancer specific mortality. A recent meta-analysis found a significant dose-response relationship between level of alcohol intake and risk of prostate cancer, showing highest risk estimates for drinkers versus abstainers in adjusted models. Now, the effects of screening on incidence and mortality. The use of PSA as a screening test has had the greatest impact on the incidence and potentially mortality of prostate cancer worldwide. Since the introduction of PSA test, lifetime risk for prostate cancer in the US has nearly doubled from 7.8% to 12.9%, and the risk for dying from this disease has decreased from just 3 to 2.5%. A recent reanalysis of the prostate, lung, colorectal, and ovarian cancer trial comparing those screened versus those not screened suggested a 25 to 30% reduction in prostate cancer specific mortality in those who are screened. Studies have also demonstrated up to 40% relative reductions in prostate biopsies and a 16% reduction in the number of prostatectomies performed per urologist. Modeling studies suggest that if screening for prostate cancer were abandoned entirely, there would be an estimated 46% to 57% increase in metastatic cases at presentation. Now, the clinical presentations.
तो क्या करना चाहिए इसमें? स्क्रीनिंग करनी चाहिए या नहीं करनी चाहिए? आप लोगों ने देखा अमेरिका में जो है वो 75% मेटास्टेटिक डिजीज रिडक्शन हो जाती है एट द टाइम ऑफ डायग्नोसिस, और यहाँ पे भी जो है वो 57% मेटास्टेटिक केसेस जो है इंक्रीज हो जाएंगे अगर स्क्रीनिंग बंद कर देंगे. व्हाट टू डू? आइदर वी गो फॉर स्क्रीनिंग और वी शुड अवॉइड इट. स्क्रीनिंग के नेगेटिव जो है वो पॉइंट्स क्या हैं? एनीवन स्मार्ट पोस्ट ग्रेजुएट? नोमान, आप ही बता दूं.
So screening should be done for prostate cancer. The negative impact that it can diagnose the underlying disease and cause over treatment enthusiastically.
स्क्रीनिंग का इसमें ये भी था ना कि ओवर ट्रीटमेंट एंड ओवर डायग्नोसिस, यूएस की जो कॉस्ट होती है वो भी कॉस्टिंग भी बढ़ जाती है. वहाँ तो ज़ाहिर है पूरा कि सब कुछ गवर्नमेंट ही करती है. यहाँ पे तो खैर ये हमारे पॉपुलेशन में इंसिडेंस इज नॉट प्रॉपरली डॉक्यूमेंटेड.
Because of these reasons which Dr. Abdullah described, plus the anxiety related to the diagnosis of CA prostate, these are the negative points against this screening, and still this topic is debatable on Medscape. Articles are coming in the favor, articles are coming into the criticism of this screening, but still there is an important point that where there is a high risk, when patient is coming to you with symptoms and when patient is coming to you with familial history, then you must go for it, so that these high risk people should be investigated and should be diagnosed in earliest possible stage of the disease, so treatment can be given to these patients. Mortality is not increasing and decreasing because of this early diagnosis or whatever. The reason behind this is, once again, that same point Dr. Abdullah pointed out, that testosterone is only being converted into dihydrotestosterone in the prostate. And when these patients are being diagnosed and testosterone effect is being inhibited by the treatment, this treatment is again the factor when patient is going towards the mortality, because total energy of the body and homeostasis is disturbed with the treatment of prostate cancer. So this is debatable. You are diagnosing it, you are treating it the early stage of the disease, but still patient's mortality is not declining to the substantial level of the treatment. But the one thing which patient is gaining is the quality of life, and that quality of life should be the aim in the treatment of prostate cancer.
Now, moving forward to the clinical presentation. First of all, the symptoms. A vast majority of patients with early stage prostate cancer are asymptomatic. The presence of symptoms usually suggests locally advanced or metastatic disease. Obstructive or irritative voiding complaints, including hematuria, may result from the local growth of tumor into the urethra or bladder neck, or from its direct extension into the trigone. Metastatic disease to bones may cause bone pain. Metastatic disease to the vertebral column with impingement on the spinal cord may be associated with symptoms of cord compression, including paresthesias and weakness of the lower extremities, urinary or fecal incontinence. Whereas the signs, which will include DRE, in which you will find induration or nodularity. However, most prostate cancers are not palpable at diagnosis, and a negative DRE does not obviate the need for further evaluation in men with elevated PSA. Locally advanced disease with bulky regional lymphadenopathy may lead to lymphedema of the lower limb. Specific signs of cord compression relate to the level of compression and may include weakness or spasticity of the lower extremities and a hyperreflexic bulbocavernosus reflex. Now, diagnosing, we should know that screening, which we discussed about earlier, refers to the testing for disease in healthy asymptomatic population, whereas diagnosis is the identification of disease among individuals who show signs and symptoms. The first would be digital rectal examination. Before the availability of PSA testing, physicians relied solely on DRE for early detection of prostate cancer. DRE has only fair reproducibility in the hands of experienced examiners and misses a substantial proportion of early cancers. PSA between 4 and 10 nanogram per ml has a positive predictive value of 20 to 30%, whereas that of PSA above 10 nanogram per ml is 42% to 71%. However, there is no single normal threshold of PSA. PSA levels are elevated by approximately 0.12 nanogram per ml per gram of BPH tissue. In men without BPH, the rate of change of PSA is 0.04 nanogram per ml per year, compared with 0.07 to 0.27 nanogram per ml per year in men with BPH, who are between the ages of 60 and 85 years. Patients whose PSA increases by 0.75 nanogram per ml per year are at an increased risk of harboring cancer. Higher PSA density values, more than 0.15 nanogram per ml per cc, are more suggestive of prostate cancer, whereas lower values of PSA density suggest BPH. Can anybody tell how PSA density is calculated? We have been doing this a lot in our prostate OPD.
Serum PSA divided by prostate
Volume, yes. PSA divided by volume.
and how we assess the volume.
By transrectal ultrasonography. Imaging for prostate cancer diagnosis include transrectal ultrasound, axial imaging, which includes CT and MRI, bone scan, and PET-CT. Can anybody tell why PET-CTs are then done in this kind of cancer? So,
to diagnose if still PSA is rising, then to rule out metastatic disease or any focus of the disease present in the body.
yeah, you're right, but it mainly helps us to find out the micrometastasis, because macrometastasis would be visualized on CT and MRI, where if the metastasis exists at a molecular level, so PET-CT would tell us about that.
Anything else? Like what we discussed, one thing is
Micrometastasis.
micrometastatic.
Failure of the disease, failure of treatment, and
But as far as the diagnosis is concerned, a high PSA with a continuously negative trust biopsies.
right, high PSA with negative biopsies, right.
माइक्रोमेटास्टेसिस सीटी स्कैन पे पेट सीटी स्कैन पे कैसे डायग्नोज होगा? Who is telling this? What should be the size of metastatic lesion which can be identified on PET CT scan? From where you have read this point?
माइक्रो के मीनिंग हम आमतौर पे हमारे जहन में क्या आता है? What is micro? Very small.
You should.
Small clinical type. और PET की limitations क्या है? एक simple lymph node है, for example, किसी को germ cell tumor है और हम उसका PET करवा रहे हैं, तो PET की limitation क्या है? It cannot pick a disease of a size less than अगर कोई इसकी माइनर डिटेल्स है वो मुझे
0.5.
आमतौर पर पैड जो है वो तो साइज असेसमेंट के हवाले से एक तो डिजीज एक्टिव हो और साइज सेंटीमीटर प्लस हो, फिर तो दिक्कत है। अब आप कहते हैं माइक्रो मैट्स पिक करेगा, ये हिसाब से ही कहते हैं।
CT scan is an imaging, na? And this imaging, when we are doing for prostate cancer, we are going with PMSA PET scan. So it will diagnose the lesion which is secreting PSA in any lesion inside the bone, liver, or lungs, or brain, wherever. But when lesion is significantly larger, 0.5 centimeter, then it can tell you that there is something disease lesion over there. It will differentiate the disease from other lesions. Like if bone scan is telling you that there is a disease in the bone, vertebra or somewhere else, but you are not sure that this is metastatic prostate cancer or not. PMSA PET scan will tell you that this lesion is
Secreting
prostate
PSA.
cancer metastasis.
Yes.
But micrometastasis is a separate entity. Your molecular biomarkers like TSA will tell you that there is something disease somewhere, but you can't see on imaging because there should be a cutoff level of size of the lesion.
Size of the lesion. Right.
And even for a PSA, like we have different level of PSA. Like people used to say if it is 20 plus PSA, then there is more chances of metastatic lesion.
Right.
But there is nothing absolute. One important thing is
Now comes the biopsy. The initial prostate biopsy is done when initial diagnosis of prostate cancer based on informed decision making is in an asymptomatic patient, or when a suspicious DRE finding, or if you feel a prostatic nodule. To diagnose prostate cancer with symptoms suggestive of prostate cancer, or the symptoms which are suggestive of metastatic disease, or in the setting of prostate cancer detection on routine transurethral resection of the prostate performed for presumed benign disease. Repeat prostate biopsy would be done when there is rising or persistently elevated PSA, atypical small SNR proliferation, which has 40% cancer risk, or extensive or multiple biopsy sites with prostatic intraepithelial neoplasia, suspicious lesions on prostate MRI, to differentiate local recurrence versus systemic disease with PSA recurrence after local ablative therapy. Now, staging, we have two types of staging, the clinical and pathological staging. Clinical staging is the assessment of disease extent using pre-treatment parameters, which include DRE, PSA values, needle biopsy findings, and radiological imaging. Whereas pathologic stage is determined after prostate removal and involves histologic analysis of the prostate, seminal vesicles, and pelvic lymph nodes if they are dissected as well. The pathologic staging. Pathologists assign a primary grade to the pattern of cancer that is most commonly observed and a secondary grade to the second most commonly observed pattern in the specimen. However, the pathology grading practices have changed over time such that Gleason pattern 1 and 2 are rarely assigned. So Gleason pattern 3 corresponds to low-grade disease, pattern 4 corresponds to intermediate grade disease, and pattern 5 corresponds to a high-grade disease. Now, clinical staging, as we've already discussed, we'll do this with the help of DRE, truss ultrasound, or needle biopsy, or imaging. So if the disease is clinically impalpable, you do a DRE, you don't find any kind of lesion, it's a T1 disease. And if you do a TURP and the specimen that you've retrieved undergoes a histologic analysis, and less than 5%, 5 or less than equal to 5% of the resected tissue has disease, it's a T1A. If more than 5% of the resected tissue has disease, it's T1B. And if the disease is detected from elevated PSA alone, and there is normal DRE and imaging, then it's T1C. Again, if you do a DRE and you feel a nodule or some induration, it's clinically palpable and it's T2. If the tumor involves less than half of one lobe, it's a T2A disease. If tumor involves more than half of one lobe, it's T2B disease. And if tumor is involving both lobes, no matter how much size of the disease is, it's a T2C disease. If the tumor extends beyond the capsule, it's a T3 disease. Extracapsular extension on one or both sides, it's a 3A. Or if the seminal vesicles are involved, either one on both sides, it's a T3B disease. T4 disease, in here the tumor would be directly extending into the bladder neck, sphincter, rectum, levator muscles, or into the pelvic side wall. It would be said as N1 if the metastasis is found in a single regional lymph node, which is less than or equal to 2 centimeters in dimension. N2 if there is metastasis in single, which is more than 2 but less than 5 centimeters, or in multiple lymph nodes, none exceeding 5 centimeters size. It's an N3 disease if metastasis is found in regional lymph nodes, which are more than 5 centimeters in dimension. So single lymph node less than 2 centimeters is N1. Single lymph node between 2 and 5 centimeters, or multiple lymph nodes all less than 5 centimeters, it's N2. And if the size of the lymph nodes is more than 5 centimeters, it becomes an N3 disease. Likewise, M1A would be said when distant metastasis is found in non-regional lymph nodes. M1B if the disease is found in bones, and if other than bone, if the disease is found to other sites, it's an M1C disease. Thank you.